Hello and good afternoon. It's good to be back. I'm your host, Caroline, as always, and this is again our next online patient meeting tonight. It's good to have you all here as well. Please let me know that you can hear me. And tonight we are having another topic to discuss, another special expert. And this time it's Dr. Rami Wakim. And hello, Dr. Rami. How are you feeling? Hope all is
Hello.
good and going
Yeah,
well today.
all is good. Thank you so much. Can you hear me okay?
Yes, I can hear you okay.
Very good.
So I believe that our patients, yes, they have just confirmed they can hear us both, which is good. Thank you so much. And
Fantastic.
as always, I just want to mention that all those events, we have started them on the 1st of April and we are continuing with those events till the end of June. There are plenty of top experts with us already. There were plenty of topics, and I always want to thank to our ambassadors and partners because, of course, it is all possible thanks to their support as well. So you can see them, of course, on the screen here.
Definitely. Yes.
And now, of course, let me just introduce you to Dr. Rami Wakim. And Dr. Rami has prepared his presentation today. Just so you know, Dr. Rami Wakim is a reproductive medicine consultant, and he prepared a presentation on the topic how to prepare for IVF and what to expect during treatment. So, Dr. Rami will start with his presentation, okay? And of course, after that, as always, we will have a Q&A session. All you will need to do is just simply type in the all the questions in the chat section so that Dr. Rami can simply help you out a bit. And I'm sure he will. So don't hesitate. Just ask your questions so that he can help you out. All right. And I guess we can simply start, right? Dr. Rami, are you ready to begin with the
Yes,
presentation?
I'm ready. Thank you so much.
Excellent.
Thank you, Caroline. So, my topic today, good evening, ladies and gentlemen, and I would like to present my topic today about how to prepare for IVF and what to expect during treatment. Basically, I thought of this topic as it is mainly addressed to the general public and the patients who are like would like to know more and to see what is new in the field of IVF. I'm not giving you a lot of statistics and bombarding you with messages that it is, that you might find a little bit more difficult to assimilate. Here is just like a chat to enlighten you about what are your options and how can we improve things. So I'll move to the next slide, which is starting with a quote of this famous philosopher, scientist. And I like this quote, if you always do what you always did, you will always get what you always got. And this is true. And this is perfectly applicable to our IVF day-to-day business. So IVF, if I just remember, like when we started 78 and then it went all through, we had like a very steady increase in success rate. And why is that? Because we are always looking to how to improve things. If I recall quite well, with me being like a fellow at the University College Hospital, for example, we were like quoting around like 30 to 33% success rate. And now look at what we can offer as success rate for now. We are talking not less than 40, 50, 60, and even 70% in special group of patients. So my duty here is to enlighten you about your options and how can we improve things from here. So how do we prepare for IVF? And when you want to start somewhere, I think knowledge is the most important thing. Knowledge leads to better informed choices, and it's all about informed choices here. I'm only here to guide you, but it is at the end of the day, it is you and me who are going to choose what is better plan for you. So, as I have rightly said, the knowledge is also for both clinicians as well as patients. So it's not for the patients only, but also the clinician should be knowledgeable so that they can give you the most up-to-date statistics and what is new in the field, so that we can just be able to have more clear, informed choices. So what we know already and what is new. I will just classify my topic into a male fertility as well as female fertility, the advances in the IVF lab, and the famous topic of add-on, because the add-on are a subject that have been coming more and more in the topics of this webinar, and I have been listening to it quite some time. So I thought that maybe it would be a good opportunity to discuss all this together. So what we know, and in male fertility, for example, so far we know that the basic analysis is a straightforward semen analysis, and this is more than enough, and to assess the male fertility potential, which is right, as well as how to improve things if there is a little bit of compromise on the number, of the motility, of the morphology. We always know that have some greens and improve your lifestyle, quit smoking and alcohol and things like that. So this is the mainstream. Obviously, we are always advising a healthy lifestyle and cutting down on smoking and all this stuff that can have a negative impact on the semen quality. However, in the late, for example, like in the last 10 to 15 years, we have been focusing more on two things. One is improving the sperm quality. So that's one. And the other topic, which is as most important as the first one, is choosing the right sperm. So this has been actually the focus of our thinking and our scientific advance regarding male fertility. So improving the sperm quality has been of utmost importance, and this has been picked up by so many pharmaceutical groups and companies that has helped us a lot in supplementing the male in the couple to enhance the sperm parameters. And these form of supplements came as evidence-based, having everything needed in the whether sachets or tablets in order to improve the semen quality. Obviously, instead of picking up multiple supplements, the trend now is to get everything as if like in one product, that it is helpful and easy to use, whether sachets, whether tablets, but in a way that this is one of the advances we have seen. Also, we have tests now for seminal oxidative stress prior to antioxidant therapy. This is a huge now debate, and talking about the antioxidants. And obviously, in my practice, I hear a lot of people coming to say like how we are already on antioxidants. We know what to take, and but we don't know, is it enough or not enough? So that's a good start. Is it enough, or what can we do? Because as far as I'm going to talk to you about, more antioxidants doesn't necessarily mean better or getting an improved fertilization potential. The other aspect is we are going to talk about sperm DNA fragmentation test. I'm sure like you have heard about these tests, and these tests are sophisticated and came up in the market in the last 10-15 years as well, like to help to improve in cases, for example, of recurrent miscarriage, in cases of unexplained infertility. What do we do? Do we look at just the sperm, or do we have to maybe try to see if there is any damage of the DNA. And that's why we call it DNA fragmentation. We look at the DNA which is present in the nucleus of the sperm, and then having a good look at it, and then classify it to have like a meaningful way to address this issue, and in consultation and while taking further plans for management. Then we have recently started to see companies advertising for fertility chips. And fertility chips, I don't know how many of you know about it or have heard about it, but it is actually in the market and it is very well available. I will come to this and show you exactly. Fertility chips is a very promising potentially helping the male to choose and to help us to choose in the lab the right sperm in order to have a higher fertilization potential. Also, we know obviously the PISA, the TISA, which is like percutaneous sperm aspiration or testicular sperm aspiration or extraction. However, micro-TISI is now being practiced by the andrologists, especially in cases of azoospermia, in order to find sperms where consistently we have azoospermic samples. And this has statistically proven that through this technique we can improve pregnancy potential for the couple. Also, I don't have to mention that sperm cryopreservation is a very important thing, because once the sperm is cryopreserved and then thawed, it behaves exactly like the fresh sample. So I would like to reassure patients that thawing a sperm sample is as good as fresh regarding fertilization. Now, a little bit of more focus on the oxidative stress that can cause eventually DNA fragmentation if it is not addressed. And we have, some very nice advancement in this field. One of them is Myoxis. That it's very simple. It's a machine that you can have it in your clinic. It doesn't have to be like in a lab. And basically, if you see on this side that this is like a slide where we put this semen sample, just 2 drops of it, and then we insert it in this sensor socket. So basically, what it displays a screen, and this calculates for us what we call the ORP values, which is oxidative reductive potential. And this indicates like the higher the value, that means that there is a tendency for a higher oxidant activity relative to the antioxidant activity. So if I'm making it clearer to the patient, that means that we don't like higher values. We don't like higher numbers while assessing the semen, because basically, if it is high, that means that the sperm is exposed to a higher oxidative stress, and that means we have to have an antioxidant on board. Now, how much antioxidant on board? This is going to be guided by the improvement of the current assessment and the values that are present. So, for example, if I have someone with a very high oxidative stress and gives like some antioxidant supplements, maybe I can retest this semen sample in 2 months, 3 months time, and see whether he is still needing for more or that's have improved things. Once it has improved, there is no point in increasing the antioxidants, because as I'm going to tell you later, that antioxidation is not good for the sperm quality as well. So as I have mentioned, DNA fragmentation is the test which is used in various indications. So what are the main indications for sperm DNA testing? We have varicocele, for example, unexplained infertility, recurrent pregnancy loss, IVF and ICSI failure. What I mean, like failed fertilization in IVF, and lifestyle risk factors as well. So people like who have some lifestyle issues with whether like they work in, for example, like dye factories, or they are like in a special sort of environment with higher pollution that can affect the sperm. This is test to provide an answer for this. And this is the ESHRI 2017 guideline regarding recurrent pregnancy loss. So what they say is that the main cause of DNA damage is oxidative stress. Obviously, this can be exacerbated by smoking. Obesity is very also like we have to tackle it. And sperm DNA damage and oxidative stress testing should be offered to couples following even a single miscarriage after fertility treatment. So we suggest that the ways to prevent sperm DNA damage caused by unhealthy lifestyle. So couples should be advised how to have a healthy lifestyle. So men would be advised to test for semen oxidative stress prior to embarking on additional dietary antioxidant supplementation. So this is an ESHRI guideline to tell us that we need to test it before additional dietary antioxidant supplementation. And always we know like vitamin C and E and minerals like selenium and iron decrease the level of the reactive oxygen species. So it's good, but not to indulge on very high concentration. Moving to the female fertility, I have well, my talk is going to be like addressed on the egg and then on the endometrium and implantation. So what has been happening in the egg? Basically, there are two parameters to assess the egg. One is the quantity and one is the quality. The quantity is mainly assessed, which is the ovarian reserve, is mainly assessed by two things. One is blood test and one is scan. The scan is intrafollicle count, and it's only basically for prediction, and it's very subjective. The AMH is the only objective way to assess the ovarian reserve. It's a quantity. It's a matter of assessing and giving advice about where we are in the kind of reserve. You have a higher potential and reserve potential. That means that you have plenty of eggs, or you have average amount, or we are low. So in few words, this AMH testing does not mean that if it is low, for example, you are going to have your menopause very early, or you cannot ovulate, or you cannot get pregnant on your own. It doesn't mean anything like that. It just helps us as clinicians if for example, it is low regarding in view of your age, and we need to tailor your medication accordingly in an IVF cycle, for example. This is very helpful for us to tailor the medication and to address you in the correct dose, because a higher dose would be more inclined to ovarian hyperstimulation, and a lower dose would lead to cancellation. So AMH came to help us to identify what is the right dose for you. On the other hand as well, like if it is very high and we are very happy about it, a lot of people, especially single women, come to me and then would like to have like a fertility MOT, and their question mainly is, can I wait? Or do I have to go ahead and try for now? So this is another advantage of the AMH to help us to plan for the further fertility plans or pregnancy plans of the couple. Now, the quality is another issue, and the quality is directly proportional to age. Unfortunately, we cannot change it because nature is working exactly like this. You are born with as we say, all your eggs in two baskets. And by age means the more we age, the more, naturally speaking, we are going to lose our reserve. Now, there is a lot of questions regarding, like, can I improve this AMH? Can I improve my reserve as quantity-wise? Unfortunately, no. What you have is what you got. The other thing is regarding the age. How can I improve? Can I improve the quality? You get like people, patients asking, can I improve the quality or how to improve it? Yes, there are ways, and the most important one, in my view, is fertility cryopreservation. So, as options to overcome the poor quality, fertility cryopreservations come number one, egg freezing or vitrification of the eggs. And why is that? Because you freeze your eggs in time. If you freeze it at 30, it remains 30. So even if you have to use them when you are 35, when you are 37, your egg will behave exactly like as 30. So all your statistics will be based on 30. All the Down syndrome screening will be based on 30. So it's fantastic opportunity and scientific advance. And I really encourage everyone between 30, 35 to consider like egg freezing as a practical option to preserve their fertility. Also, there is in vitro activation that has been like going on for a few years, and it is a breakthrough advance in premature ovarian failure. Mitochondrial transfer, unfortunately, it's despite being a very good idea, getting a mitochondria from a younger patient and then infuse it in the egg of the donor, so that we don't mix the genetic component. However, despite very promising results, it is still within scientific context. So I've heard a lot of people like, what is about mitochondrial transfer? Can we do it? Unfortunately, it is not yet a plan that we recommend. It's only in scientific. Also, we have autologous transfer of ovarian tissue or ovarian tissue cryopreservation up to ovarian transplant. There are some centers, they are very sort of advanced in this, and they do ovarian transplant to use it at a later stage. AMH, as I have said, I've already mentioned that AMH is always in relation to age. So when I was at UCH and we did this scientific paper published for AMH, it was an independent value, so we couldn't really tell does this value is it okay for a younger patient, is it okay for 39 years old, for 30 years old? We didn't know. But now recently we have seen an improvement in the interpretation of AMH with a bracket in between to tailor it between age groups. Like, for example, like between 35 and 39, your AMH should be anything between 1.1 and 53. So you can see the variation, and that's why you can tell like how this is not to tell you like how many eggs you left, but it's just a guide on how long can I wait before starting treatment. And this is the paper that I have published while at UCH with this with the group, and it was like a combination of antral follicle count, anti-Mullerian hormone, and inhibin B. The summary of it was that the anti-Mullerian hormone is basically the best single predictor because this is an objective test, and it doesn't have to be related to the periods. You can do it any time of the months. It doesn't have to be related to day 1 to 3 like we used to do with the FSH. Now, coming to another very important subject, and advances in it has been tremendous. embryo implantation. So we are talking about how the embryos will implant. Now, if you go under the green section here, it's logically to understand or to realize that euploid embryos, euploid means normal chromosomes, normal genetic formation and chromosomal formation, do implant, the majority. And logically speaking, aneuploid embryos means embryos with abnormal chromosomes usually do not implant. However, this gray area, and it is rightly put in gray because it's a gray zone. There are still euploid embryos, but they don't implant. So this is a dilemma that has been facing us for a long time. You have a euploid embryo that should implant, but it doesn't. So it doesn't happen like first time, it's okay. Second time, it's bad luck. Third time, there must be something like which is really questioning us. Should we do more? And this is what I'm going to talk about. So that led us to the implantation potential and recurrent implantation failure. So in the endometrium, we are talking about the endometrial receptivity as well endometrial embryo interaction. And then we started with endometrial scratch. If you remember, this endometrial scratch was in vogue, and in the HFEA is still amber. Amber means there is no robust scientific evidence that using it is going to improve your live birth rate. And then I will reiterate this at the add-on section of my talk. Also, embryo glue, I will talk about it later. ERA. ERA is the endometrial receptivity analysis or array. And this was like a breakthrough because this helped us to know what we call a window of implantation and personalized ET. So what does this mean? In simple terms, in order to have an embryo that implants, we need to supplement the endometrium with progesterone, okay? And this progesterone, by experience, by logic, a blastocyst of 5 days, we give like 5 days of progesterone. And this is like 120 hours. However, in those kind of circumstances that they don't implant, we were thinking whether using ERA can tailor my timing of progesterone. So it could be pre-receptive or post-receptive. Pre-receptive means you need less progesterone. Post-receptive means you need more progesterone. Very simple. And it doesn't apply to everyone. It is mainly in those cases where we really do not have an answer. Okay, so it's very helpful. It's a tool that we can use that can guide us about the perfect window of implantation and hence having a very personalized ET. Then came the endometrio. Endometrio is very nice name because it includes three. That's why trio is mentioned. So endometrio. And it includes three tests, 3 in 1, basically in the same biopsy. So I don't do 3 biopsies. It's the same endometrial biopsy. And this includes the ERA test together with Emma and together with Alice. And this, by the way, they are not the names of girls that we have chosen like by chance. Like why we didn't call them Gemma and Caroline. It doesn't work like that. And Emma stands for endometrial microbiome microgenomics analysis, as well as Alice is the analysis of infectious chronic endometritis. So basically, one is at looking at the microbiome because we felt that maybe the microbiome, the milieu of the uterine cavity, which is full of good bacteria and bad bacteria, if we adjust the microbiome, especially the lactobacillus, maybe we can improve things. Also, by checking about chronic endometritis, which we cannot see in by our own sort of eyes, with even with a gold standard like hysteroscopy, this can be treated and help to improve things. And very, very recently, as to last week, We knew that there is a new thing coming up called Embrace, and this is a non-invasive test avoiding even the whole scenario of invasive embryo biopsy. So what are the advances in the IVF lab? We are hearing more and more about natural sperm separation and selection, which is basically the fertility chips. Also improvement about the egg quality. What about the embryo quality? And then the embryoscope, which is the time-lapse technology, or TLT, and this is under the umbrella of artificial intelligence now. So if you hear artificial intelligence, means this kind of technology we use. We definitely hear now about PGTA. This term has replaced PGS, which was pre-implantation genetic screening. Now it's becoming pre-implantation genetic testing for aneuploidy. Also, PGTM has replaced the old acronym PGD, which is pre-implantation genetic diagnosis, and replaced with PGTM for monogenic disorders. So this is the chip, and as you see, it's very, very simple slide and very simple physical concept of microfluids. And basically, there are two types of chips. One is for mainly used for IUI insemination, and one is mainly used for IVF and ICSI. And the manufacturers and the company claims that using it gets us like you inject, like you put the sperm on one side, and then you collect it from the other side, having passed through this kind of filter. And on the other side, there is they have evidence that it is more normal forms are recruited, as well as very minimal DNA fragmentation. So if the sample had, for example, to begin with, a high DNA fragmentation, we are delivering a sample which is very high in normal forms and very low in DNA fragmentation. Obviously, these are retrospective studies, small studies, and as scientific people, we are just saying, once we have like a high number of cases and numbers, and in a randomized controlled study, for example, to test robustly the actual significance and the effect of this. Obviously, after this kind of scientific improvement, and if they, for example, showed through randomized controlled study that they are definitely improvement in the sperm parameter, this will be like another breakthrough, which I'm looking forward to hear more from it. Coming to the egg quality, so basically this is just to show how IVF is very helping us and you to understand that this is not only for treatment, because IVF can be also diagnostic. So as a diagnostic tool, I can easily differentiate between a normal egg and an abnormal egg. Look at how many varieties of abnormal egg I can find under the microscope. I can see a granular egg, or refractile body, or an ovoid shape. And all these are different varieties of abnormal eggs that if we see, at least we maybe have something to discuss regarding why am I having failed IVF, or why this didn't work the first time. So at least, apart from being helping to treat the patient and to get success rate, but this is very important to know that IVF also is a diagnostic tool. Regarding the embryo quality, look at the day 1 embryo when it divides to 2 cells. Day 2 is 4 cells. Day 3, for the morula, and then the blastocyst, the very nice blastocyst. And this is actually textbook. This doesn't happen in normal day-to-day life in the lab. So as I'm going to show you here, judging the embryo quality, I would like to challenge every one of you to tell me exactly which embryo is better quality in order to transfer. I have these two in front of me on day 5, and I need to transfer one. Which one do you choose? I bet most of you will tell me the one on the left is the most good-looking one. So this is the one that to transfer. However, you'll be disappointed to know that this embryo actually did not implant, and the other embryo on the right side was the one that implanted and produced a nice, embryo and fetus and baby. So judging by the looks doesn't work. So that's why it came with the idea of the embryoscope. So embryoscope is basically an artificial intelligence way. We said, okay, maybe if we put a camera inside the incubator, and basically there is a camera inside that takes a picture every 15 minutes for 5 days. Just imagine the amount of photos it has been taken. And this is only to see if these embryos are behaving the way it should be as by the book. Like after how many hours they have divided into 2 cells, and how many hours they have reached day 3, and these blastocysts, have they reached day 5 exactly where they should have been, or they have been a lag in the development. So yes, it's a very fantastic tool. However, it takes a lot of effort from the embryologist to apply statistics and to know exactly which one to transfer. It's very useful in a very busy IVF unit. However, if there is a small IVF unit with very senior embryologists, and they can really follow the embryos day by day and see their development, I think this will lead us to the same success rate. Now, the biopsying of the embryo, and I'm just going to give you a very simplistic diagram about how to perform PGTA. It's a biopsy basically on day 5, where the blastocyst, you can see the blastocyst here is like an expanded with an inner cell mass which will produce the embryo later, and this is the trophectoderm. So basically the biopsy is taken from this side, from the ectoderm here, trophectoderm, and we analyze it basically, and depending on this, we have one of 3 answers. One is completely normal, one is completely abnormal or aneuploid, and there is a mix of the two. The mix of the two is either low mosaic or high mosaic, and this depends obviously on it will start more debating about whether we should transfer back, and this involves genetic counseling. So is it harmful or not? Because we are still biopsying an embryo. And that's why, what's new? The new thing is that this is the PGTA that we are performing. So it's a NGS sequence, next generation sequencing trophectoderm biopsy that we take from the embryo biopsy. And now the new thing that we are just trying to have an idea about it is the non-invasive method for aneuploidy testing, and based on the fluid, which is the NGS in the spent, what we call the spent blastocyst media. It's exactly as if you want to compare it to NIPT, for example, the fetal cells detected in maternal blood for testing for Down screening and chromosomal anomalies. So it's very promising, and we are waiting for more details about it. So there is a lot of genetic solutions in the IVF clinic, including microbiome, receptivity, and now recently there is something called expanded carrier screening, And a colleague of mine that just had a presentation about it like 2 days ago, and showed that how is important in order to rule out very, very slight, small percentage of miscarriages due to co-carrying. So the co-carriage is existing when you have two mutations, one in the male partner, one in the female partner, happen to meet and then produce an abnormal recessive gene, for example, and causing miscarriage. So what about the add-on? So add-on, I came up on two papers, which is very interesting. One was published in 2015 and one was published in 2020, so very recent. And it was fascinating to see how they what they said when they were reviewing this add-on in 2015 and what is the latest in 2020. These two groups are very, very important groups. They are both British groups and gave us a very solid details about their understanding about the add-on and what works and what doesn't work and what is the evidence for it. So I know a lot of people who have been asking this lots of time about whether I should or not. So I'm just putting in front of you what was said in 2015 and what is said in 2020, and it's up to you to take the decision as well. So the first one I start with is the hydroepiandrosterone, the DHEA. Well, now it's being labeled as the hydroepiandrosterone. In the 2015, I'm writing it in black, and the 2020 is the blue one. So in the 2015, basically, they said if in the absence of good quality evidence, we cannot be recommended at this time. The 2020 came with a Cochrane review revealing higher ongoing pregnancy rate and live births. However, the benefit was not statistically significant. Okay. And there was a very famous study. It was a DHA intervention to treat ovarian aging. It was a single center randomized controlled study. At the end, it failed to demonstrate any benefit from the use of DHEA in women with diminished ovarian reserve. So based on this, we cannot support it. The growth hormone, both of them came up with three statements which are exactly similar. One is no benefit was apparent from using the growth hormone adjuvant in normal responders. So there is no benefit whatsoever from someone who is normal responder to give growth hormone. The advantage of adding growth hormone seemed to be only limited to treatment cycle with GnRH agonist protocols only, and no significant benefit was found by adding the growth hormone in an antagonist cycle. So this was replicated exactly in the 2020. However, there was an additional add that some of the beneficial effects of growth hormone on the outcome that have been suggested may be a result of its action on the endometrial receptivity. And this is new, and this is very interesting. And maybe in the coming years, we will know more about the effect of the growth hormone on the endometrial receptivity. Coming to antioxidants, including CoQ10, the 2015 paper came up with further evidence is required before CoQ10 can be recommended for all low responders. We know that CoQ10 improved the oocyte cumulus and quantity. A recent study failed to demonstrate any improvement in clinical outcome. Also, in view of the antioxidants, we know that, as I have said, excessive formation of reactive oxygen species can induce oxidative stress and lead to cell damage or death. However, both extremes, whether you use more oxidative, obviously, or more antioxidant, they are both counterproductive. Regarding artificial oocyte activation, it's a good concept to activate, like maybe artificially this oocyte. However, it has been only limited to scientific trials, so we cannot recommend it clinically. Heparin, there is conflicting evidence. There was insufficient evidence to establish its potential in recurrent miscarriage without thrombophilia. I'm not talking about thrombophilia. However, there is a growing evidence that other than its antithrombotic effects, now we are thinking of heparin as immune modulator that help with the modulation of the decidualization of the endometrial stromal cell and hence endometrial receptivity, which is something very new and good to research it further. The aspirin, however, a Cochrane review of 13 randomized controlled trials have suggested that administration of aspirin did not improve pregnancy rate for IVF patients. And more recently, another Cochrane review stated, especially with people with recurrent miscarriage, whether associated with thrombophilia or not, did not find any benefit of the use of aspirin alone or in combination of low molecular weight. This is unexpected, but the conclusion was to routine aspirin use is not advocated. Immunotherapy as well, implantation rates were not shown to be improved at all with immunotherapy. Steroids, short-term use of prednisolone may be offered in selected cases, especially in recurrent implantation failure or recurrent miscarriage. Due to low cost and perceived short-term use, may be offered unless future evidence directs otherwise. So we're still very cautious regarding the steroids. Intralipids, you can see for yourself that a double-blind, even a randomized controlled study showed no increase in clinical pregnancy rate in group of men who were treated with intralipid. Endometrial injury or endometrial scratch. We have conducted so many sort of studies, and a randomized controlled one recently was conclusive in showing that endometrial scratching does not confer any benefit to reproductive outcome. Assisted hatching in 2015, unless a proven beneficial effect on live birth rate is established, assisted hatching should not be offered. So the latest meta-analysis on studies on assisted hatching, look at that, like 36 randomized controlled studies with almost 6,500 participants, found that assisted hatching gave a significant increase in clinical pregnancy rate, but in the last 15 randomized control that looked at the live birth rate, there was no evidence of benefit from assisted hatching. Time-lapse and pre-implantation genetic screening are good tool to have in the lab. Embryo glue, the latest Cochrane review with almost 4,000 participants demonstrated a moderate quality evidence for improvement in clinical pregnancy rate, however, with a slight associated increase in multiple pregnancy rates. So what were the conclusion by the authors of the two papers? New techniques are the way to progress. However, they should not be marketed prematurely. I fully agree. For most intervention, we have lack of satisfactory evidence may be interpreted as evidence of lack of benefit. And this is a kind of area that we have to abide by evidence-based medicine, like we always, like what we always do. So, my final thoughts would be that folic acid and vitamin D remain the pre-conception prenatal supplement of choice. These are really the two most important vitamins that you should be on before trying. A preconception optimization, obviously BMI optimizing, apart from optimizing BMI and lifestyle changes, stabilizing any chronic medical condition, stopping, not decreasing, stopping coffee, alcohol, and smoking. This is the chance to consider testing for expanded carrier screening as a couple to prevent co-carrier miscarriage from this combination. And more expensive treatment doesn't always mean it's better. So this is what I want you to know, that spending like a lot of money and saying that this is better is not always the case. And also, please do not be fooled by marketing tactics. So marketing tactics like, come to us and then we'll increase your success rate by, I don't know, 3 times, 4 times. This doesn't mean anything. So please just be, be mindful and read the fine print. Also, patience. So I want to advise everyone not to be very sort of rushing into success from the first IVF fresh cycle, because now success rates are not measured by fresh cycles only. So please get away from the single cycle paradigm to look at longer term cumulative outcomes of treatment. As it stands now, we think that the end point of success in IVF should currently be the full term singleton birth rate. So the full term mean not preterm, because a preterm delivery is not a success. So a full term singleton means not twins, birth rate per started IVF treatment. Also, a word about alternative medicine. Alternative medicine such as acupuncture, hypnotherapy, reflexology, homeopathy can be of help. Counseling is always there to help you when needed, and it's free and it's available. And I will end with my final thought, like I started with my quote. I quote here that we always strive for perfection in everything you do. So we hope to get the best that exists and make it better, and try to improve things. And this is only to benefit from, the higher success rate means more and more couples will be happy, having happy ending. And thank you so much.
Excellent. Thank you so much, Dr. Rami, for your presentation, for lots of details. Thank you so much. That was definitely interesting and very informative. And I'm sure lots of patients have found it useful. So once more, thank you so much. Well, and in such case, are you ready for some questions? As we do have already, actually.
Definitely, yeah, I'm happy.
Excellent. I am glad to hear this then. So let's start with the very first question. And you have mentioned this, yes? It's regarding supplementation. So what supplements do you recommend for men and women? So if you could just mention.
Now there are some supplements that we see in the market, like for both, actually, for men and women. So it's becoming like addressed to both men and women. I cannot recommend one thing in particular, but they are all based on evidence. I cannot say evidence-based, like all the evidence that we have gathered regarding what can work to improve the sperm parameter, for example, or the egg quality, they have put them together. Now, this does not imply that if you take this, your chances will become much better. This in a way that cannot be interpreted like this. However, if you have a supplement that covers everything that the sperm or the egg needs to nurture in order to help not deteriorate things, which in itself is an improvement, is helpful.
All right, excellent. Thank you so much for your very first question, and of course for your assistance with this. And there's a similar actually question. So, how can I improve the quality of my eggs?
Well, I have touched it in my slide, and the improvement of the quality of the egg is unfortunately, the quantity and the quality is very, very difficult to improve. The IVF concept is basically, it's trying to help you with what you have. So basically, if you are at a certain age, we cannot change it. The quality of the egg will be always in relation to your age. If you are 20, you have a young egg at behaving as 20, 30 the same, 40 the same. So I cannot improve the quality of the egg, but what I can do is to try to get the most out of this scenario, which is whether quantity or quality, and improve things by trying to create embryos through IVF. And this will mainly act on the time to conceive. So instead of trying naturally, for example, at home or with less successful uh, uh, um, procedures, for example, IVF is the one eventually, not necessarily in every case. However, if IVF, you are expecting from it getting more eggs than you are already having, this is a myth. This is not true, because if you have a antral follicle count on that cycle that you are starting any form of treatment, I cannot generate more than this. So if you have 5 antral follicles, do not expect to have, for example, 8 eggs or 9 eggs. So regarding the quality, can I improve my quality? The only thing for now is cryopreservation of the egg. So my advice to you is, if you are in this category that you would like to have or to proceed with egg freezing, go for it, because this is the only way to improve dramatically the quality of the egg and hence the quality of the embryo in the future.
Okay, thank you so much for, again, your question, and of course your assistance, your answer to this. And there are more questions coming up. The next one is a bit longer one. Okay, so let's have a look. So my husband and I have 3 frozen sperm samples, but the sample we want to use with the best quality is a slow frozen assisted 2007 sample in Australia. The DNA fragmentation test was done by Professor Don Evanson, and he said this was the best sample out of all samples. My worry is that it was slow frozen assisted, which was the case back then. What is your opinion with it being defrosted and used, and also how many straws should be used as it needs to be transported to a clinic abroad? We don't want to use recent sperms. My husband is older and not as good quality.
Okay, thank you. Well, let me reassure you that cryopreservation of the sperm is completely different than cryopreservation of the egg. And the reason we had a very high success now in egg freezing is because we have shifted from the actual way that we were doing the cryopreservation to vitrification. So the main difference here was that the egg using the slow freezing that we used to do has given us very slow or very low success rates in the past, maximum maybe 10%. And the problem was with the thawing. So the thawing was the problem, is that because they were like frozen, and when you defrost them, basically the ice particle forms and then they create this kind of ice particles. And this is where the problem was. Vitrification is completely different issue. The vitrification is instant freezing, that there is no time even for ice to form when you defrost it. So that's why we are giving like higher success rates now as 50% for the egg. However, this does not apply for the sperm. The sperm do very well. They have been always frozen. Like we started freezing sperm very much longer before freezing the eggs. The starting freezing eggs in 2000 and maybe one, maybe two. However, the freezing the sperms was long before that, and it was always the slow frozen. So I wouldn't worry about it much, because sperms are really like behaving very well after so whether the slow frozen or the new techniques. So regarding the second, how many straws should I be using? This is completely a lab discussion. So from clinician point of view, I would abide by what the lab is advising you.
All right, excellent. Again, thank you so much for your thorough question and, of course, your answer to this. And well, let's have a look, okay? Because the patient has just added a follow-up. So post-thaw motility of the sample was 40% and concentration was 34.
You see, like brilliant, very good.
Okay, all right.
Yeah.
Thank you for clarification then. Excellent. All right. And it looks like there is another question. So yes, let me just show you this here. We had 4 IVF cycles, 2 in 2012 and 2 last year. Every time we got collection of egg, which is good quality, doctor said good quality of embryo transfer, but final result always come negative. I don't know why that happened 4 times. What we need to do for success?
Okay. So that's a common question, like I get like in a scenario of a busy IVF clinic. So it's not uncommon to come across this kind. Unfortunately, I'm so sorry to hear this that you were not successful, but there is a lot of information here that we need to know, like the kind of stimulation that you have, your BMI, for example, to start with, whether the eggs produced were of good quality, how many mature, how many fertilized. So it's not only like what is the end result, but I would like to know the whole sequence of events until you produce all these egg and the final result. Have we had how many numbers of good quality embryos, as well as how many frozen, for example? Yes, it's good quality to like to start with, which is good, but don't forget that I don't know the age, I don't know like what is the state of the lining of the womb, what was the thickness, was it did you think about like using one of these techniques that we used for maybe implantation failure? Because if they were like blastocyst and the good quality, as you said, I would put a question mark on like, do you get enough progesterone, for example? Do we need to know more and take a biopsy and see? And on the other hand, if your age as dictate is, say, for example, above 40, I would definitely advise you to test the embryos, because we need to know one way or another, are the embryos the problem, chromosomally speaking, or is there a problem in the implantation? And that's as an end result. But however, leading to this, I should know like a very thorough studying of your stimulation protocol.
All right, excellent. Thank you so much for your question. And I just want to mention that if you would like to get like more details, yes, you can of course get in touch with Dr. Rami so that he can help you out, of course, as well. And let me just show everyone that I will send a link this way. You can simply ask any additional questions using, sorry, there is an option to simply ask your questions. It is forwarded to Dr. Rami, and I'm sure he'll be able to help you out with more details as well. All right, excellent. Thank you so much for this. Next question is ready here. I have had 2 failed attempts, both with IVF and ICSI, due to me having natural killer cells. Is this something you believe in? Where there is the best place to treat immunology in the UK and overseas? I am 45. Would you recommend trying egg donation? And would this work if I have NK cells?
Good question. So basically, you had 2 failed attempts, both with IVF and ICSI, and you had the kind of diagnosis that this was due to having natural killer cells. And this is the first myth that you have to we have to clarify. as I have mentioned, the papers that have been published under randomized control studies did not show any relation from the natural killer cells, whether in peripheral blood, whether uterine natural killer cells, are the reason of you not having a successful attempt. So this is the first thing that we need to realize, that it doesn't mean that treating them will definitely make this pregnancy successful. However, there are centers. I'm not saying that they don't treat immunology. Of course, there is centers, but do I believe in it or not? I believe only evidence and what has been on the scientific papers. So I am very critical, but I don't mean by that I have to basically ignore sort of any attempt to see like if there is any improvement from a technique that I can use. But the most important thing to know and to realize that uh, don't fall into this um, idea that if you were not treated through this immunological technique, that means that this was the only reason for your failure. This is one. If you are 45, as you said, like there is a major issue of here, for example, to talk about more is the quality of the egg. So the quality of the egg is as we say that has an implication on with age. It has an implication on the quality of the embryos. So unless we, yes, you said like recommending trying egg donation, if you have tried like twice and the outcome were like really unsuccessful, egg donation is obviously at 45 would give you a higher success rate in comparison with trying with your own eggs. But obviously everything has to be balanced. And would this work if you have NK cells? If you have an egg donor and egg donation cycle, a lot of IVF sort of clinics would recommend to have like a basic studies of the NK cells. However, this is not the mainstream in the IVF field for now.
All right. Okay. Thank you so much for the clarification to this question, of course, as well. Okay. Next one is also ready. Quite a short one. So, what is IVA?
IVA is in vitro activation, and this has started in Japan with a breakthrough idea, then became like a successful outcome from this is very, very limited to a very specific group of people who have premature ovarian insufficiency, so long they have some antral follicles. And by this scientific breakthrough and advance, they take these kind of antral follicles and they will grow them outside in the lab with the egg, as well in injecting this with so many sort of factors, and then replacing it back to the ovary, and therefore they will be responding to the actual stimulation drugs. So this is a scientific sort of the concept is still in the scientific issue. We cannot recommend it only for a clinical aspect. However, it is promising to know that what it will lead us to. So there are like a few recorded cases worldwide, but we will want to know more of this through, you know, the advances of whether or not it is going to be in the mainstream in the near future.
All right, excellent. Thank you so much for that question and your explanation to that. Okay, we will go back to actual question in when it comes to supplements. Okay, so
Yeah.
I thought that eggs could be improved in quality and quantity by Q10 supplementation. Anything you can add? You have
Well,
mentioned this
I have
already, but
I have mentioned this already, and I advise you to read this paper published very recently in 2020 about add-on, and they have all the information about Q10. I'm just like putting this information, and because it was like like fascinating to know like what is the outcome now of all this information, and it's up to like basically I have no sort of inclination to be favoring, but this is for everyone to read and then be to know exactly whether this is helpful or not.
of course, excellent. Thank you so much for this again. And well, okay, well, sorry, I will just go to the next question as it is in this. So, is there any harm from taking Q10?
There is no harm, but we are talking about is there any benefit? So this is the situation. So we are talking about is there any benefit? So if there is no proven benefit, so it's very hard, like argument whether taking it will improve things.
Of course. Okay. Thank you again for the clarification. Of course, as you can see, those questions are quite common,
I know.
and yes, exactly. And actually, there is one more. Okay, so when we are on this topic, I will show you this one. So I've been taking 200
Same.
milligrams
Yeah.
of ubiquinol
Okay,
CoQ10
then. Okay, then.
daily to improve my cell quality. Do you suggest this may be more determinal than I thought?
It's not detrimental, as I said. It's not detrimental, but we have to be aware of the evidence. It's not detrimental as much as like I want to have like a more sort of green light to say like it does definitely improve things. You see, there is a big difference. Is it detrimental? I cannot say it is detrimental, but at the same time, do we get, is there any trial that has improved like the outcome of live birth? It wasn't.
All right, excellent. Thank you so much once more for this. Okay, well, so if you could take a look at this one. So how much folic acid and vitamin D, and is folate better prenatal vitamins?
So folic acid is either taken alone or as a part of prenatal vitamins. So basically, folic acid is 400 micrograms per day. Vitamin D is 1,000 units per day, and usually multivitamins are coming like under one sort of generic sort of containing everything, including folic acid and vitamin D. So every vitamin combination is in a way good, but so long they have at least 400 microgram and at least 1,000 units of vitamin D.
And this was, of course, a follow-up. So the donor should be taking such vitamins as well.
I mean, basically, the folate is mainly into relation to a pregnancy. So the donor, whether she takes vitamin D or folic acid, will not make a huge impact on the egg because you need it for the actual pregnancy.
Okay, and is too much folic acid, or vitamins D dangerous?
Well, there is definitely higher doses of vitamin D is not recommended. So you have this. There is the 5,000 unit. There is the 10,000. There is the 80,000 unit. So this is not for recommendation. Okay. So 1,000 units should be more than enough. And folic acid or folate, unless you had a proven miscarriage, recurrent miscarriage, then we can advise this 5 milligram. Or you had diabetes, or you had a previous, for example, neural tube defect baby. So we recommend then a higher dose, which is the 5 milligram. That's it.
All right, Okay, perfect. Thank you so much for the clarification to this one as well. Next question is also ready as well. Okay, so even with a proven donor as well as the surrogate, do you suggest that an amniocentesis be done on the surrogate? Would you recommend this for single as well as with twins?
The amniocentesis now is not based on age or whether the donor was young, or it's not based on this, because we take all this into a statistical equation, and then have a like assessment by, for example, nuchal screening test with all the other blood tests that we do in the first trimester, and based on that we would recommend if you are at high risk or a low risk.
All right, excellent. Thank you so much for that again. And so what are the differences between antagonist or agonist protocol?
Okay. So antagonist protocol is a shorter version of the agonist protocol. Agonist protocol is was the one that was the classic one to start with, because it was meant to shut down the ovaries basically by a dose of an agonist, what we call an agonist, so GnRH agonist, and this makes the ovaries dormant, in order when we start the actual stimulation dose of the FSH, it will help us to improve the the number and the progress of this follicle without a premature LH surge. So we start them on day 21 before the actual start of the period, and 2 weeks after we start with the actual medication. The antagonist came back as a newer version, and it's a very good idea that we start with this FSH stimulation, and we add up a GnRH antagonist to inhibit the LH surge. So they both function the same. So one is an agonist protocol is starting like before starting the cycle, like day 21, before the actual commencement of the treatment, and the other one we started like 5 to 6 days after we start the medication, and both of them are basically to prevent the LH surge and premature ovulation.
All right, excellent. Thank you so much for the explanation for this as well. Next question. Right here, what are your thoughts on PGTA based on the latest red rating from HFEA? I had 3 cycles of IVH 41 with PGTA. First cycle 2 out of 2 unemployed. Second cycle 3 out of 6 unemployed. 3 no results. Third cycle 6 out of 11 in unemployed. 3 no results. The no result embryos had poor grading on outer cell mass.
I just wanted to know what was the outcome with the genetic counseling. So did you have genetic counseling? So this would have been like, more geared like as to what kind of aneuploidy. So it's not only like I have like aneuploidy or mosaicism, but the type, yes. So basically, if there was no genetic counseling, it's very difficult to know exactly what, because some hereditary problems are like repetitive, and they should be a different management from something that it is less likely to happen again. So I advise you strongly, like with this, to have this genetic counseling and take it from there.
Of course, thank you so much. Follow-up was mixed results, usually chromosome 16 or 13.
Yeah, 13 is one of the, the main chromosome that we look for is like 13, 18, and 21. And this is unfortunately incompatible as well, like with life. So basically, it is it's in a way that it was good detected before like replacing them back. So What is the next step forward? It will depend on the whole scenario and the age and whether you accept egg donation or not, and stuff like that. So
yes, there is one more, of course, additional information. So about to go through another cycle of IVF, age 42, and debating whether to do PGTA based on latest red rating.
So you mean you have been you didn't have a single frozen embryo euploid? Did you have any frozen?
And 3 embryos.
Frozen.
Let's see.
Euploid.
Yes.
So why would you like to go for another cycle if you have 3 frozen embryos and they are all good quality, and we know that they are euploid? So my advice to you in that case,
transferred not successful. Okay.
So you still have one, isn't it?
Still have one, yes.
So I think to go for this with maybe combine it with an ERA testing, that would be the best way forward, actually. So at least, like, I know from one hand that the embryo is normal, and then I would like to know more why you are not having implantation, maybe hysteroscopy, maybe ERA testing. So yes, I understand banking for sibling is good, but you know, I think in on the balance, you could go away with things, with simple things like transferring a normal embryo. However, if you'd like to go ahead, this has to be definitely geared and directed, if I may say, by the genetic counseling. So since you have said, unfortunately, you didn't have genetic counseling, so I really recommend you to have and see what is the recommendation.
All right, excellent. Thank you so much. Just one additional information.
We know that the normal looking embryos had employed. I showed you a slide that no matter what, like, you cannot judge by the looks if they are euploid or unemployed. So you have a very good quality embryo, good looking, like under the microscope. However, it is chromosomally abnormal.
Okay, thank you so much for answering this one, of course. Sorry, so PGT. Okay. So patient is asking so PGT or not.
After careful examination, we have to know, like, whether, like, I'm doing this PGTA, and because we have like 4 times we have done like PGTA, and then we had a repetitive abnormality. If PGTA is recommended by I don't know, like if it was recommended because by age alone and then repeated aneuploidy, then the benefit of it might overcome the risks of having PGTA.
Okay, understood, of course. Thank you so much for your question. And I just want to mention that, remember, if you would like to get some more details, I'm sure Dr. Rami would also need some more details as well. So you can simply use the link I have just sent, and that way you can, of course, ask your questions there as well. And we will be slowly finishing. There are like 2 questions left. So let's get to the next one. So I understand from the literature that blastocyst transfer day 3 has proven to be better for women of my age, as the eggs retrieved are usually more ripe than younger women. So the development age is actually older, and day 5 is too late in the embryo development age. Is this something you would do for an age advanced patient?
Look, there are 2 issues here. One is the egg quality in relation to blastocysts. So we know that in the initial phase of the blastocyst formation, at the first day 1, day 2, day 3, they are determined by the egg quality. However, from day 4 or 5, they are more sperm driven. So what I'm trying to say by this, that if you have a good quality and good number of eggs and good number of embryos that you have developed through to day 3, and then after like having, for example, 6 day 3 embryos, we end up with 1 blastocyst. We often say that this is more likely to be driven by the sperm. So does this mean that we have to transfer only day 3 to you regarding to your age? It's not relevant, because still the blastocyst is the most embryo proven to have an implantation potential. So if I compare the implantation potential of a day 3 or day 2 or day 3 or day 5, definitely the blastocyst has got the highest implantation potential. So that's one. There is nothing called developing to day 5 is too late in the embryo developmental age, because I don't know where did you because maybe I'm not understanding what is too late in the embryo there, but this is the kind of the norm of having an embryo developing till day 5. However, it all depends also on the number. So if, for example, I have 1 or 2 embryos, or eggs, and then develop into embryos, and then you are after counseling, you're happy to have 2 embryos to put back, I don't see the reason why I should wait then till day 5. So that's the issue here. So the issue is mainly dependent on the risk of obviously multiple pregnancy, the risk of having a late diagnosis of failed development into blastocysts by just observing them under the microscope, which would have eventually have happened anyway in the naturally speaking. However, this myth of being too late in the embryo development age, I don't think this is something that I would go with the terminology of it. However, as I said, like if you have 1 or 2 embryo, then this is more than enough to transfer it like on day 3. And most of the IVF clinics would not wait till day 5 to transfer it.
Okay, excellent. Once more, thank you so much for explaining that. And let me have a look. As I mentioned, there was 1 question. Now we have 2. So let's get to this one. Why is it better to go for a low stimulation cycle if you have a low AMH? Wouldn't an antagonist approach be better to try and produce more eggs?
Very good question. So low stimulation or mild stimulation or natural stimulation has got the advantage of having a very low dose, and when we know that there is a low MH on board, and especially in very low poor ovarian reserve, a low stimulation has proven that it is much milder into stimulating the eggs and providing a better quality eggs. So you have to understand that I'm not challenging the ovaries to produce many eggs. This is number 1. We have to accept that low MH, no matter what I do, I will not be able to produce. Remember what I have said before, like if, for example, you have 2 or 3 antral follicles to start with, if I give you an antagonist with 450 units, it doesn't mean that I'm going to get 8 eggs or 9 eggs out of these 3 antral follicles or 2 antral follicles. So that's number 1. So if I have 1 or 2 antral follicles that I'm aiming to get into maturity and they grow so that I can collect them, rather than pushing very hard in order, on one hand, it will not benefit you. Second is to get me into a state where you can simply, the ovaries just be as if like not responding. Or on the other hand, the quality of the egg demonstrated by this high dose of FSH are proven to yield more aneuploidy embryos. So if I have, for example, 3 eggs developed into 2 embryos or 3 embryos, in the mild stimulation, I'm expecting to have at least 1 or 2 normal. However, if I do an antagonist cycle and then I try to produce 3 or 4, I may have all 4 aneuploidies. A concept out of this has came out, which is banking of embryos. So it's like when you hear a 3-cycle package, that's exactly the situation that we are in here. So a low AMH, we know that it's not going to respond with a higher number of eggs. So the way around this is to do for example, a 3-cycle package. Okay, so that means that I stimulate, collect the eggs, create embryos, and bank them, and do not transfer. And the same on the second, the same on the third cycle. So that means that after these 3 cycles, I have more choice. First, to know the number, how many number of embryos produced, and this comes in dual advantage. One is I'm transferring, for example, 2 embryos, and then out of these 3 or 4, I have collected 5 embryos. So you have still 3 frozen. So that's fantastic. If you, for example, would like to have a PGTA on these embryos, that means that I have a choice, and to do them on 5 is much better than to do PGTA on 1, because then in that case it's not worth it. So it's got advantages. It's milder. It's less harmful on the body, and third is less expensive. So there is a lot of advantages in this.
All right, excellent. Thank you so much. And in the meantime, we have like 2 questions in regards to this actually. Yeah, so let's have a look. So are results of low mild stimulation protocols included in the success rate, or only normal protocols are taken into account when collecting for success rate in your clinic and other clinics generally?
Good question. Basically, the low and mild stimulation protocols are under-labeled like as poor prognosis patients. So in IVF clinics, if they want to be like clear and very sort of transparent, they should include this in their success rate. So this is as honest sort of answer. So basically, yes, they would be included in clinics, even if the success rate is low, so long we know that they are offering low and or mild stimulation protocols, because some units do not offer this mild stimulation protocol simply because maybe they don't believe in it. But if it is in the kind of treatments that are offered by this clinic, you will see even on their website, there should be a section between 30, 35, between this and that. So those patients who had mild stimulation, or especially for the category which is older than the 30 to 40, will be included and will have obviously a smaller success rate. However, this is more than enough to make someone happy with their own eggs.
All right, excellent. Thank you so much. And once more, there is a question on that, okay? Similar, I mean, is there any evidence for mild stimulation in patients with high AMH in older age to get better quality of egg?
It's a very good question. However, in older age, to have high AMH is debatable or very unlikely. However, I see this on occasions. So it's not something that we are talking, like daily. Say, for example, like a patient who is 41 or 42, I've seen AMHs of 33 and 35. Is very good. Okay. But remember, I spoke about two things. One is the quantity and one is the quality. So AMH is 22 at 41. That's very good. That's very good. So in that sense, both protocols can be. It depends on what has been already done. So the short answer for a 41 who has an AMH of 22, a full like sort of classic IVF stimulation work better in this case. However, the mild stimulation is more reserved to much lower AMH or much older group of patients.
All right, excellent. Thank you so much for explaining again this one. Okay, and so the question is, what are the risks of PGTA?
Risk of PGTA is always like the embryo that does not survive the biopsy. So basically, we see. However, the biopsy, if you are talking about PGTA at the blastocyst stage, with using it from the trophectoderm, is very sort of risky. So we are saying that less than from like I would say like 5% not surviving the biopsy, and then on sewing back, then you'll see that the embryo did not survive. So yes, there is risks in PGTA like any other, but definitely the risks of biopsying a trophectoderm in the blastocyst is much less than biopsying a day 3 embryo, for example.
All right, excellent. Thank you so much. And if you could just clarify one last thing for the patient here. So apologies if you answered this earlier. So for patients 42, 43, generally is low stimulation better?
I cannot say that. Every patient is different. Okay, so at 42, 43, I need to know what is the antral follicle count, what is her AMH, has she done already classical protocols before, what kind of eggs she has produced, how much was the level of the E2 that she has produced. So it's very difficult. It's not like categorizing people like on age 42, 43. I rather have, a very sort of medically fit patient at 42 or 43 with AMH, which is not as low as really like say be below 5 or below 2, but in the scenario of having at least like an average AMH, and she has not tried an IVF for antagonist cycle or agonist cycle, definitely in that scenario I would go for more antagonist cycle, because I would need, like, here the main input is, can I get as many eggs as possible in order to end up with because like you can get as much a higher number of eggs but ending up in lower number of embryos, and this lower number of embryos, I want to use them. One is for the fresh transfer and then see if I can just freeze more. So for the mild stimulation, if she has very good AMH, I would say, it will be, she will not have a good chance of reaching her potential in, it would have been like a good trial to recruit as many eggs as possible before becoming like more 43 and 44. So if I FSH of 7.5 at 42, that's excellent. So any FSH less than 10, we consider it as normal.
Excellent. Once again, huge thank you for your
Welcome.
question as well as your assistance with all of those questions. We will be finishing for today, but thank you so much, Dr. Ram. It has been excellent. So many um, details you
Thank you.
provided to our patients. So I am sure they are very, very satisfied. And thank you to all of you for just simply joining us over and over again. I know some of you have been here a few times before, and it's always good to have you here. And I'm sure you have been able to get some answers. And Dr. Rami, as you can see, there are some
Thank you.
thank
Thank you so
yous
much. Thank you.
for
It
you
was
as
amazing.
well.
Thank you. Have
And
a lovely weekend.
exactly. I just want you to see one more. Thank you, brilliant. Thank you for your patience with all the detailed questions. The best session so far. So thank you so much for
You're
this.
most
It's
welcome. Okay. Thanks.
excellent. Okay, and just let me remind everyone that this has been recorded, so you will still have a chance to simply re-watch it. Okay, it will be uploaded after the weekend. It will be uploaded on our website, myivfanswers.com. And of course, I can only encourage you to join us at 8 p.m. UK time. So in 20 minutes, we will be back with another topic. Moving on to sperm donation with Eloise Eddington. Sorry. So if you would like to hear her story, I just can only encourage you to join us. And well, Dr. Rami, once again, thank you so
Thank
much
you so
for
much.
supporting our
It was
initiative,
a
for
pleasure.
joining us today,
It was
and
a pleasure.
have a lovely and relaxing weekend as
Thank
well.
you.
Thank you
Same.
all.
Likewise.
Bye.
Bye. Take care. Take care.